The contribution of adverse childhood experiences, often called ACEs, to health and development. I am Claire D. Coles, PhD, a professor in the Department of Psychiatry and Behavioral Sciences and Pediatrics at Emory University School of Medicine, Atlanta, Georgia. I am the director of the Center for Maternal Substance Abuse and Child Development. And in this center are Mother to Baby Georgia, which is a teratology information service, as well as the Emory Neurodevelopment and Exposure Clinic, which provides clinical services to children 0 to 21. I would like to acknowledge support for the center, which includes the State of Georgia Department of Behavioral Health and Developmental Disabilities, the Health Resources and Services Administration, the Organization of Teratology Information Specialists, the National Institute on Alcoholism and Alcohol Abuse, and the National Institute on Drug Abuse, both of which are part of the National Institutes of Health, the Centers for Disease Control and Prevention, and the SKK Foundation. I have no conflicts of interest to report in this talk. When a child is born, we all hope that they grow into a healthy and happy adult. But this is not always the case. Some children struggle. How can we understand developmental psychopathology? How can we understand the developmental path from birth through later problems in health and behavior? Those who study these issues often talk about them in terms of risk and resilience. It is clear that some individuals can transcend many challenges in life, while others seem to be seriously affected. What is the field of developmental psychopathology? This is a theoretical approach that takes a developmental perspective that understands the changes that occur over time in terms of development and understands psychopathology in this framework instead of thinking about it as something that occurs very similarly to adult behavior. In studying these issues, the goal is to understand how multiple factors that occur over childhood impact later development in childhood as well as development in adulthood. This approach examines the variety of risk and protective factors that contribute to later mental and physical health. And they often include 3 categories of factors. And these may be individual characteristics, characteristics of the child's family, and environmental factors. And I'm going to talk a lot today about one factor that has been shown to be a strong predictor of later adjustment in health, and that is adverse childhood experiences, or in the short, ACEs. Risk is an important concept in understanding developmental psychopathology. And there are a variety of factors that might place a child at risk. They're typically thought of in terms of individual characteristics, characteristics of the caregiving environment, and characteristics of the greater social environment. And we can also think about those things which are clearly a combination of some of these factors. In terms of individual characteristics, certainly genetics, particularly if there's a genetic disorder, are going to have a huge effect on outcome. Temperament has been studied extensively, and it has been demonstrated that certain types of temperament have an effect on the degree to which a child develops, for instance, anxiety disorders or depression. Sex at birth is an important determinant of outcomes. There are a number of comorbid conditions, other mental health issues, for instance, like ADHD, certain personality characteristics, and prenatal exposures and other factors which may induce stress both in the fetus and in the child later. The caregiving environment is frequently looked at in terms of risk, and these things may involve the parent's style or how they interact with the child, certain family environmental factors, and family psychopathology, including substance abuse and mental health issues. So the social environment within which the child and the family live have a huge effect as well. Things that have been studied include low SES or poverty, disadvantaged population, the access to educational opportunities or to an intervention is necessary, and environmental effects like war and national disasters. There are a number of risk factors that have been studied extensively, and they have been found to affect emotion and behavior. Just to name one of the individual characteristics, low birth weight has been found to have a relationship to other factors during gestation, like the maternal nutrition, substance use, tobacco smoking. In addition, we've looked at the persistence of low birth weight into later childhood, as well as whether or not that is predictable to the individual's later status. Environmental and social factors are frequently studied, and these include socioeconomic status, which we usually take to mean parental education, job status and income, race, ethnicity, and similar kinds of status inequities. There are a number of them, and they may vary from one country to another, from one culture to another. There are also events affecting the larger society, which then come back on the family and the child. And these may include war, a recent pandemic, certain natural disasters, and a number of economic events. The parenting and family environment have been a focus of much study. And as I discussed in my last talk, attachment is frequently examined. Another area that is very frequently examined is parenting style. And this has proved to be very interesting because there's an intersection of parental warmth with type of parental discipline. And it has been demonstrated that there are certain types of parental discipline, for instance, authoritative style, which produces a much more positive outcome in children. Finally, certain mental health and substance use issues in the parent do have a number of different effects on the growing child. And this brings up the question of adverse childhood experiences, and I will discuss that more fully. It's important in thinking about all this to understand one theory that is now very commonly accepted, and that's the developmental origins of disease, of health and disease hypothesis, also known as fetal programming. And this was first described as the relationship between low birth weight and later outcomes. And here are some table or some graphs with thanks to Joanne Weinberg that describe the relationship between cardiovascular disease and low birth weight, as well as insulin resistant and low birth weight. And as you see, as birth weight goes down, the probability of this disease goes up. This relationship was first published by David Barker's group in Southampton, England. They showed correlations between low birth weight and adverse health outcomes. These include cardiovascular disease, insulin-resistant diabetes, hypertension, and other conditions. Not surprisingly, this raised a lot of questions, and there resulted in a good deal of research, some of it into what underlies this connection. And it became apparent that low birth weight itself was not really the cause of later adverse outcomes. Rather, low birth weight was really a proxy, and we may think of it as a biomarker for prenatal environment, for adversity during the prenatal period, for stress during the prenatal period that led to these later conditions. It is very likely that there are common factors underlying both this intrauterine growth retardation and the physiological function that produce risk for later disease. This leads us to the question of adverse life events research. Adverse life events have been related to negative outcomes in childhood and adulthood. Most often, this has looked at physical illness, mental health problems, social problems, and substance use. There has been less information on social and developmental outcomes like education and career success. All of the research done indicates that it's the cumulative burden of adverse events experienced by an individual that lead to a significantly negative outcome. Is typically not a single event. In order to document and study this phenomenon, the Adverse Childhood Experience Questionnaire has been developed, and it is used to determine the extent of the burden experienced by an individual during childhood in order to relate that to later developmental events. If you would like to learn more about what the Centers for Disease Control and Prevention in the United States understands about this way of viewing the impact of experience on later health and development, you can go to the website that is referenced in the bottom of this slide. According to the Center for Disease Control and Prevention, adverse childhood experiences can be defined as potentially traumatic events that occur in childhood. These things can include violence, abuse, and growing up in a family with mental health or substance use problems. They believe that toxic stress occurs as a result of these events, and that these can change the brain development in the individual and affect how the body responds to stress as the person grows older. They also note that ACEs have been linked to chronic health problems, mental illness, and substance abuse in adulthood. The study that brought the idea of ACEs to the public attention and led to a huge body of research that followed it was done by Felitti et al. In 1998. This group published a paper entitled Relationship of Childhood Abuse and Household Dysfunction to Many of the Leading Causes of Death in Adults. These researchers surveyed adults, more than 9,000 of them, in the Kaiser Health Maintenance Organization in the United States. They asked questions about childhood experience of abuse, as well as household dysfunction, and then collected data about the individual's current health status, presence of disease, and various adult risk behaviors, which included smoking and STDs, or sexually transmitted diseases. In analyzing their data, they found that the persons who had experienced more than 4 types of ACEs, or adverse childhood experiences, had 4 to 12 times higher risk for alcoholism, drug abuse, depression, and suicide attempts, making mental health issues the most significant correlation with earlier adverse childhood experiences. But they also had 2 to 4 times higher rate of poor current physical health, which included substance use and the presence of adult diseases, including cancers, heart disease, chronic lung disease, orthopedic injuries, and liver disease. This study highlighted a problem that had not been thoroughly understood previously and produced a wealth of follow-up research in order to more fully understand the relationship between these early childhood experiences and later outcomes. How were these adverse childhood events defined? First, they had to occur before the age of 18. Then, based on Felitti's earlier paper, they're defined by categories, abuse and by household dysfunction. And when they refer to abuse, they're talking about psychological, physical, or sexual. In terms of household dysfunction, and in this initial paper, this included substance abuse, mental illness in the parent, and the mother being treated violently, what we would call domestic abuse, and criminal behavior in the household. This further research examined this, and I've listed a couple of studies on this slide, which you can follow up with if you're interested. And these found that those with at least 4 ACEs had a much greater rate of negative health outcomes, as much as 12 times greater. And then with each additional adverse event, there was an increase in the odds of poor health by 9%, an increase in the problems of mental health by 32%. There were factors which ameliorated these problems, and that had to do with subsequent positive family functioning, which can serve as a protective factor in the face of increasing adversity. The Centers for Disease Control and Prevention identifies the following types of ACEs. Physical abuse, which is any intentional act that causes physical harm through bodily contact. Sexual abuse, which is any forceful, unwanted, or otherwise abusive sexual behavior. Psychological abuse, which is any intentional act that causes psychological harm, such as gaslighting, bullying, or guilt tripping. Emotional neglect, failure to provide emotional support, love, or affection. Physical neglect, failure to provide basic needs such as food, shelter, and clothing. Substance abuse, living with someone who abuses drugs or alcohol. Mental illness, living with someone who has a mental illness. Parental separation or divorce. Incarceration, living with someone who has gone to jail or prison. Domestic violence, being exposed to domestic violence between parents or caregivers. Death of a parent or caregiver. And placement out of the home, placement in foster care or other alternate living arrangement. I'm now going to provide an example of the relationship between adverse childhood experiences and later mental health and physical health in a cohort of individuals that we have followed. The study is entitled Fetal Alcohol Spectrum Disorders in Adult Health and Neurobehavior. These individuals were identified either prenatally or early in childhood in Atlanta, Georgia, and Seattle, Washington in the United States. We reconnected with them when they were about 39 years old on average and collected information about not only their early childhood experiences, but also their current health status. Here is a slide showing the number of adverse childhood experiences in this sample of adults prenatally exposed to alcohol. In this sample, there were both people who were controls, which is to say they were not exposed to alcohol. There were people who are here labeled PAE, who were exposed to alcohol, but who did not have fetal alcohol spectrum disorders. And then there were another group who had fetal alcohol spectrum disorders. And in the graph, you will see that the sort of brown bar are males and the pinkish bar are females. The total number of adverse childhood experiences was higher in those people who were alcohol exposed. And they were higher among females than males. You will note that if we remember that having 4 ACEs or adverse childhood experiences put you at risk for later health problems, you will see that those people in our alcohol group either have more than 4 such experiences or are approaching that number. You will also note on the other side of the slide that except for having a parent who died and having a parent who is depressed or a caregiver who's depressed, on every other one of the childhood experiences that we assessed, those people who were prenatally exposed to alcohol had significantly more such experiences than did those in the control group. So on 9 of 11 factors, they had higher numbers of those people reporting having experienced this kind of problem during childhood. This places, if we believe this theory, this would place individuals with prenatal alcohol exposure at a very high risk for negative outcomes. Here are some of the outcomes of this research. We ask about a number of mental health outcomes, including anxiety, depression, bipolar disorder, psychotic disorder, ADHD. And here you see a graph showing all mental health problems. Those people who had alcohol exposure have a higher number of mental health problems. One of the questions that one might sensibly raise, though, is what is the relationship between alcohol and all the other factors that occur in life and the probability of having a mental health disorder in adulthood? We were able to do what's called a regression model in order to look at some of the other factors. We included in this model alcohol, adverse childhood experiences, biological sex, the individual's education level, which is a proxy for a number of things, including social status, as well as access to health insurance, which is not necessarily available in the United States. When we look at this regression model, what we find is that even though more people with alcohol exposure reported mental health problems, what we are really looking at is the factors associated with alcohol. So the most significant or highly significant is the ACEs, but we also find that females are more likely, in this case, to have mental health problems or to report having them, that those people with higher education are less likely to have mental health problems, and that access to health insurance makes a difference in whether or not you're diagnosed with mental health problems. So it appears that it is not the alcohol itself which is causing the mental health problem. It is the factors associated with the prenatal alcohol exposure. I've selected some medical diagnoses to look at as well. I picked two, cancer and thyroid disorder, because they both showed a considerable effect of prenatal alcohol exposure. When we do a multi-regression on the cancer diagnosis, we find that there are three factors which are significant related to outcome: prenatal alcohol exposure, ACEs, and whether or not you have health insurance. In this case, biological sex and education do not contribute. When we turn to thyroid disorder, only two factors appear to be related to this outcome. One is prenatal alcohol exposure, and the other is ACEs. These two examples do provide us with information about the multi-determination of medical and outcomes, as well as the mental health outcomes among this group of individuals. Finally, I'm going to show you this rather busy slide that has a drawing of a path analysis. And I do this because one of the things that I think, or we think, is going on is stress. And that there are a number of factors which are associated with stress that affect health and mental health in midlife. And when we did a path analysis on this particular group of subjects, we found, using number of depression symptoms as the outcome, that there was an effect of sex, SES, ACEs, and dysmorphology, which represents having a FASD diagnosis, all contributing to the number of depressive symptoms that an individual had. This is just a graphic way of demonstrating what the regression model showed, that many different factors contribute to outcomes in adulthood, and that mental health is a function of many different things. Now, some of you may be wondering, why are we talking about adults? ACE's research seems to talk about the recall of childhood events by adults with mental health and physical problems. And this raises a couple of questions. Could there be a bias in recall? Is it possible that people who are depressed or sick are more likely to recall negative events about their childhood than healthy people are? Well, that's certainly possible. And this particular issue has been evaluated by several studies. And they have found that recall bias does not appear to be the reason for the differences that are observed here. A second important question is the same thing going on in children and adolescents as we've observed here in adults? There has been less research in this area because many people were interested in the physical problems in adulthood. But it does appear that ratings of childhood abuse, neglect, and experience of childhood dysfunction correlates highly with childhood behaviors in clinical settings. And I'm going to provide you again with a couple of examples of that. To examine the relationship between ACEs and child behavior, Freeman in 2014 conducted a study, and the reference to that study is at the bottom of this slide. To examine the question of did a higher number of ACEs predict behavior problems in later childhood, she looked at a national survey data of ACEs in children who were birth to 6 years of age, and there were about 1,670 children included. The ACEs included child abuse, different types, household dysfunction, and caregiver criminality. Child behavior was measured 5 to 8 years later, and in this case, the Achenbach Child Behavior Checklist was used. This is often called the CBCL. The CBCL has a number of outcomes, but these are summarized into internalizing disorders, anxiety and depression, and externalizing disorders, including ADHD and conduct disorders. The results were these. All types of abuse, neglect, psychological, physical, and social, were correlated so that if the child experienced one, often these experienced another as well. If a child had 3 or more ACEs, this predicted elevated levels of behavior problems when they were older. And there was a dose-response relationship observed. That is, as the ACEs went up, so did the behavior problems. Internalizing disorders, anxiety and depression, were predicted by neglect and psychological abuse. Externalizing disorders were predicted by all types of abuse. And externalizing disorders were also predicted by domestic violence. This study demonstrates, yes, there is a relationship between ACEs and child behavior, and that this is not a phenomenon that is observed only in adults, nor does this particular study depend upon recall of earlier abuse. It is, in fact, data collected external to the individual. I'm now going to present some data that we collected at the Emory Neurobehavioral Exposure Clinic in Atlanta. This clinic serves children 0 to 21, and most of the children are exposed to alcohol and drugs. We provide care throughout the state of Georgia, and we use a multidisciplinary approach, which includes pediatric, psychiatric, psychological, and educational interventions. As part of our data collection, we collect adverse childhood experiences, and we do this through a checklist which is completed by the clinician after they evaluate the child's records. So we look for multiple placements, evidence of abuse, neglect, including witnessing violence, as well as a number of problems having to do with the caregiver and the environment. I want to provide you with information from a study that was carried out by one of our residents. And again, you will see the reference at the bottom of the page. He was interested in whether or not adverse childhood experience would interact with the effects of the drugs that we are working with, which include alcohol, stimulants like cocaine and methamphetamines, with marijuana and with opioids. Whether or not these two factors would combine to produce more behavior problems in children. So he looked at 308 children divided between males and females and compared the effects of ACEs on those exposed to alcohol, tobacco, stimulants, marijuana, and opiates. The children were 1 to 18 years of age, with 60% of them being 5 years or less. The mean number of ACEs using our checklist was 3.9, which is to say almost 4. And again, we used the child behavior checklist to determine whether or not there were behavior problems. We saw more problems reported in males, as is typically the case. But females' behavior appeared to be more affected by trauma, so that among females there was a greater increase in negative behavior as the number of ACEs increased. We also found that exposure to stimulants, that is to say, cocaine or methamphetamines, showed an interactive effect with ACEs on when we looked at externalizing problems. Effects of the other drug and ACEs were additive instead of interactive. So the ACEs added to the effects of the alcohol and added to the effects of the marijuana, but the effects of the stimulant drugs was essentially interactive and multiplied when we added the ACEs to the stimulant. This, again, points up the complexity in studying these issues, but it does demonstrate that even in very young children, we see a very significant effect of these adverse child experience on behavioral outcomes. Resilience is the second important construct. Resilience refers to the ability to recover after an adverse event, success at defeating the odds despite risk status, successful adaptation despite risk, and positive development in the face of adversity. When we look at children who show resilience, for the most part, the factors that promote resilience are the inverse of the risk factors that make for problems. Good parenting, positive temperament in the child, adequate family resources, for instance. There have been a number of studies looking at resilience in children, and they generally find that stressful life events, trauma, and chronic adversity do impact the brain function and structure, and they can result in the development of post-traumatic stress disorder, depression, and other psychiatric disorders. And they also find that there are genetic, epigenetic, developmental, psychological, and neurochemical factors that contribute to the development of resilience or the impact of risk. However, it is important to note that most individuals do not develop illnesses after experiencing stress, and they're thus defined as resilient. In a sample of teenage children and young adults who were followed from the time they were born until we were able to do follow-up, we looked at risk and resilience. And we looked at a number of factors, but I'm going to tell you about serious mental health problems and substance abuse. So in this first slide, we have a question: are there characteristics of the individual that affect risk and resilience in terms of serious mental health problems? We looked at early development factors, including birth weight, gestational age, maternal alcohol use, and physical dysmorphia score, which means the individual had characteristics of fetal alcohol effects. And we found that gestational age and preterm alcohol exposure were trends, but were not strongly influencing later development. Still looking at serious mental health problems as the individual reached the early adult years, we looked at family factors in adolescence and how those predicted to later mental health problems. These included warmth and the degree of supervision provided. We also looked at family stability, exposure to violence, family substance use, and adolescent individual substance use. We found that the factors which were most related to having mental health problems later were exposure to violence. Parental warmth and positive life events also contributed to these outcomes. Finally, we looked at individual factors that were related to serious mental health problems. And these included whether or not you were male or female, what your social status or SES was, your ability level or intellectual IQ, and the degree to which you'd experience positive or negative life events. Here we found most factors were in fact related to outcome, with the exception of IQ. There was a relationship with sex, with social class, and with both positive and negative life events. Essentially, if you were a female, if you had a higher SES, if you had more positive and fewer negative life events, you were more likely to experience resilience. And of course, the inverse is true in terms of risk. So to summarize, what predicts better mental health? Well, not being exposed to violence as a child or an adolescent, experiencing a warm parental environment, experiencing positive life events as a child or young adult, and being free of negative life events. Having more resources, including access to education and job opportunities, and to some degree, having a higher IQ, being female, being born full term, and not being exposed to alcohol. In a second analysis, we looked at factors that predicted substance abuse. Looking first at family factors, we included parenting style, warmth and supervision, the child's exposure to violence, the degree of family conflict, whether or not the adolescent used substances earlier, and whether or not the adolescent exhibited behavior problems. If you will look at the table, you will see that 3 factors emerged. One was verbal conflict within the family. The second was the degree of parental warmth. And finally, whether or not the child showed acting out or externalizing behavior. To summarize, supportive families in adolescence with less verbal conflict was associated with less substance use. When we look at individual characteristics, we see that the gender of the individual or the sex at birth, the degree of negative life experiences, social class or SES, financial stress, and family stress were all entered into the evaluation. And we find that sex makes a difference, negative life events, financial stress, and to some degree family stress. To summarize, higher SES females who had fewer negative life events were less likely to have problems with substance abuse. Financial and family stressors specifically related to substance misuse. Overall, we found that the predictors of using less alcohol and drugs were full-term birth, family support during adolescence, living a life without exposure to abuse, which are the adverse childhood experiences, not having behavior problems earlier in life, and coming from a family with more resources, both financial and social, and having fewer negative life events was associated with lack of alcohol and drug abuse. How can we summarize all this? First of all, it's important to interpret development within a particular social context. That is, from looking at the population from which the group of children comes, because the population and the environment has a large effect on the outcomes. But even when you take that into consideration, The most common influence overall on child adjustment were gender or sex at birth, whether or not the child experiences negative, adverse life events, whether or not they experience violence, whether or not there is early alcohol and drug use, and appropriate parenting. You will have noticed in talking about these factors that many of them are very much family-oriented or individually oriented. And the initial studies regarding adverse events really focus very much on things that happen to the individual within the family. As time has gone on, there has been more focus on the greater environment, what is happening outside the family, within the neighborhood, within the country, overall, that may also impact the child. Not all the things that influence emotional health are individual and family-based. And research has now begun to examine how environmental stress contributed to these outcomes as well. They have identified certain environmental factors that are associated with higher risk. And these include status variables, which lead to a condition of chronic stress. And these include low socioeconomic status, where it's hard to access the things that are needed for daily life, and also belonging to a disadvantaged racial or ethnic group, whatever that is within a particular culture. We also know that social and environmental disasters produce significant stress, and depending upon the other conditions in the child's life, may have a very impactful influence on what becomes of that child's emotional development. And these can include things like natural disasters, earthquakes, floods, fires, certainly our recent pandemic, and social chaos, including war. To examine the hypothesis that the environment outside the family is also important, a study published in 2022 examined two sources of data. One was individual ACEs data collected from 1,784 randomly sampled individuals in Philadelphia, Pennsylvania, United States. Then, neighborhood variables from publicly available data sets were also accessed, and in those, 21 neighborhood variables were identified and sampled for those census tracts in which the individuals lived. And these included poverty, unemployment, race, ethnicity, social service access, healthcare access, access to alcohol and drugs, the number of overdose deaths, the crime rate, air quality, and other factors of this kind. When the results were examined, they found that individuals with higher ACEs tended to live in areas with higher poverty rates, higher unemployment, less education, more diverse populations, which in Philadelphia means Black and Hispanic, lower access to food, fewer grocery stores and so on, more reliance on food assistance from the government, and other factors of this kind. Reviewing the data, the author suggests that individuals with higher ACEs usually continue to experience harsher environments and thus have more stress throughout their lives. And this cumulative stress may be the basis for the deficits in health and mental health that are seen in older individuals. I have cited the publication at the bottom of this slide. Another terrible example of the effect of environmental stress is the trauma of war and separation on children. These data come from a study that was done in 2016, probably on children from the Middle East. And it found that in children under 6 years old, a great many showed post-traumatic stress symptoms. The rates were from 7.8% to 44.6%. Sleep disturbances are most common. Children refused to sleep alone and wanted to sleep with their parents. They had nightmares and frequent wakings. They also showed alterations in behavior and in their emotions, demonstrating both internalizing and externalizing symptoms. When they looked at children with chronic exposure to conflict versus those who had a single exposure, they found again, as we have repeatedly found, that chronic exposure to stressful events resulted in higher rates of behavior problems. And these in particular were anxiety, separation anxiety, overdependence, impairments in the mother or parent-child relationships, low frustration tolerance and increased attention seeking, more aggressive behavior, increased temper tantrums. Children also sometimes showed changes in behavior patterns. Whenever we examine the effect of stress on children, whether that stress is adverse childhood experiences as defined as abuse and household dysfunction, whether it is status variables that produce chronic stress, or whether it is social and environmental disasters that produce stress, we see the same kinds of results. If there are sufficient events of this kind, either in quantity or in the extent of the individual event, we produce a stress reaction. As this is compounded over time, if it continues and does not resolve, if there are no buffering factors in the child's life, this can lead to alterations in the central nervous system, which ultimately can lead to increased problems with mental health as well as physical health in older children and adults. This is probably not an extraordinarily insightful finding, although it is very clear that these are important factors in child development and in developmental psychopathology. But sometimes I think we overlook the cumulative nature of these issues and may attribute to other factors, perhaps just the nature of the child, what is really the effect of accumulation of stress and its very negative effect on the individual. And adverse childhood experiences, or ACEs, are one way of understanding these things. Thank you for your attention. In this slide, I have listed some articles and websites that you can go to get more information about what I've discussed. I also listed some information on the slides themselves, and there's certainly a great deal more to learn and to understand on this topic. If you would like more information, I will be happy to provide it. You can reach me at msacd@emory.edu, and I have provided my email address on this slide. I also will be happy to talk with you further or answer any questions you may have.